Good evening, everyone. Hope you're not totally webinared out. This apparently is the 80th free one, and we've also done 40 odd ones which weren't free. They were for Tipton Training Academy. Just before I start, just to plug a quick plug about our courses. We are, after COVID, we've started again. Obviously, it's going to be a little bit different. But, we're starting in September and October, and as many of you have done these courses, they're absolutely brilliant. You will recover this money in no time, one or two cases, and you'll recover all the money. We're doing it blended now. Also, it's level 7, so you can go on and do a PG Cert or a Master's or a PG Diploma. We've moved it to Manchester, Birmingham, London, it's all around the country, and there's just no excuse not to do it now. We've made it as easy as possible, even weekends if you want, weekdays or weekends. So I'm hoping that you can join us and do these courses. So for today, everybody always keeps asking me, Ash, you've got some great tips. Can you do a lecture or write a book? They even asked me to write a book on some top tips. So I've done a few. They said do 10 or 11. So because I always like to give more, I've done 11 tips. Just things that I find I struggle with, in my career. And then I found ways around either by myself or from asking other people or from courses that I've done. And these are a few of them, patients that retch, gummies, smiles, unsightly gum margins, contact points, how to repair broken porcelain, placing retraction cord, doing predictable non-vital bleaching. I know you've had one or two, but this is the Ash method, where I can predictably do it, and it just works for me. Recording RAP, again, something that's predictable and doesn't need an awful lot of skill. Even people as very low skilled like myself can do it. So it's, again, an easy way of doing it. Predictable alginates, it's a basic dentistry, but it's something we do need to get right. Crown prep bite registration, again, I never know how to do that properly, so I'll explain that to you. And my bonus one is on communication or prime speak. It's not a very long webinar, I expect it to last, hopefully only about 40 minutes, because they're short tips, they're practical tips, they're just tips on what I've gained. It's not like, massive clinical based evidence, it's just things what I've picked up over my career. So the first one is a patient that retches. For me, this was always a problem. I always worried, I've got a patient that's going to retch. I know I can't take a very good x-ray. I know impressions become difficult. And some people I've even had, where it's very difficult to examine because they just have this horrible feeling that they're going to retch or be sick whenever I'm going, my fingers are going to go in their mouth. So a couple of things that I learned about this was, one thing is, apparently it's biologically impossible to retch and breathe. So if your patient is breathing, so if they're actually taking breaths, they cannot retch. The whole idea is that the body's response is that the epiglottis covers the airway because it's worried that something's going to go down the airway, and then they vomit or they retch because that airway is covered. But if they're breathing, then the airway cannot be covered, so the retching aspect of it is covered and they won't retch. So if you can explain to a patient before you start that as long as you are breathing, it's biologically impossible to retch. So when we're taking impressions, if we can keep saying breathe, practice breathing, deep breaths, and we will find that we won't retch. So you'll get good impressions. And I mean, impressions are so important to get that impression. That's the thing we start with. It's our basic. It's like the taking the measurements for something that you're making. If the measurements are wrong, everything else is going to be wrong. But the other thing is table salt. So again, I found that it's biologically impossible. Like when we're eating, we never retch. We could have food and it's not possible. We're putting something in our mouth, but we don't retch. And why is that? Well, that's the body's response, because it knows that food is not going to be harmful. It's not going to go down the airway. It's designed to go down the throat. So it's not going to, it's not going to switch that mechanism off. So just a bit of table salt, if they put it on their tongue, and the brain, it tricks the brain into thinking that food's going to follow. Because in it, what you do, that's getting the taste buds going, thinks food's going to follow. And what you put in the mouth obviously isn't food, but the brain doesn't know that. And it tricks the brain into thinking that this is food. So when you put your x-ray in, the patient doesn't retch. And I've had patients that have had to have sedation, for an examination or for x-rays. And I've just kept putting table salt and then doing a procedure. Unfortunately, the brain, you can't trick it for very long. You can trick it for maybe, a couple of, not even a minute, maybe about a minute, half a minute. And then unfortunately it realizes this isn't food. So it's not, it doesn't work completely for impressions, but for your x-rays, for your quick examination, absolutely brilliant. As I say, I had a patient that needed sedation for it, and I managed to do exam, bite wings, and scale and polish just by keep using the salt. And you can get these sachets of salt everywhere, I usually get my daughters to raid McDonald's, and every time they go, they bring me back a few of the McDonald's sachets, but any of them will work, but it's a great tip, and it stops that uncomfortable, when you don't think, oh, I can't get an x-ray, just try it and use the table salt. So the next tip that I'd like to talk to you about is gummy smiles. So, when you've got a very high lip line, and it's really difficult when you've got a very high lip line. It's so difficult because you're going to do an implant, or, those gum levels are so important, and it's very hard to work around. So I'll show you a case. So this lady, Tanya, she's got a very high lip line, and it's how to manage this. And of course, it's quite easy, to bring the lip down. We could do crown lengthening and stuff, but it's very invasive. You could do like lip repositioning surgery, or, you can do an osteotomy, but again, it's very, very invasive. So just a little bit of Botox in the two muscles. We know these muscles. There's only two muscles that raise the corners of the mouth, and those two muscles can stop that lip from rising very high. And it's the longest named muscle in any species. It's called levator labii superiori aliqui nasi. And it's predictable. You know what they've worked out? The research shows that 5 units of azaleor either side drops the lip by 3.4 millimeters. So we can measure it, and we can predictably just bring the lip down slightly so that it's at a more even position. And if you look at it, the difference it makes, I mean, you can see that the eyes are a bit wider. You can see that there's less lines around the, if you look, I don't know if I can point. Yes, so if you look, the lines around the eyes are much less when we stop the lip rising. And these cheeks look a lot less chubby because the lip's not rising as much. And we've got a much better proportioned face than the round face that we had. And this is just with 2 very, very simple injections, which really are very easy to do. It's well within our remit to be able to do that. It's absolutely very, very straightforward. And, it's very rewarding. And so you can imagine if you were doing implants on this patient, it would be very difficult, to control the gum margins. But if you can bring the lip down slightly, you've got a lot more leeway to play with. And yes, it's not for everyone, because she's going to have this repeated every few months. So it's not going to be for every patient, but it's quite a nice way of being able to just do a treatment for somebody that's quick, easy, and makes a massive difference. You can also use it for those cases where they're suffering from Bell's palsy, so one side of the lip's rising more than the other. This lady had shingles, and she was left with Bell's palsy on one side. So this side of the lip doesn't rise like this side does. So all I need to do is just to keep this a little bit lower. And if I keep it a little bit lower, it makes everything straight. I think I've had a couple of questions. I'll just have a quick look and see whether to do those later. So the question is, what to do with table salt to make them smell or eat? Sorry, yes, oh, I didn't make that very clear. So you actually get a little bit and you get it onto their tongue. If you put it onto their tongue and let them actually eat the salt, then they think that the food is going to follow. So the brain thinks that food is actually going to follow. And then once food follows, then, although they think that food's going to follow, food doesn't actually follow. But what comes next? Your X-ray. The brain actually thinks it's going to be food. So that's why the salt works. Yeah, you don't get them to smell it or anything. You get them to actually, you take a pinch, get them to put a bit on their tongue and actually eat it. Then the brain thinks that food is going to follow. I hope you understand. It's a leap of faith. Once you've tried it, you think, why didn't I think of that earlier? Why did I not use it? Because it's absolutely brilliant. You know, as soon as I get a patient that's retching with an X-ray, my nurse knows, she gets the salt out, put it in, and X-ray is done, no problem whatsoever. And patients think you're an absolute genius. So the second question was, what kind of Botox and how much time will it work? Okay, so the Botox I use is called Azaleo, and it comes in 125 unit vials. Now, 5 units per side lowers the lip by 3.4 millimeters. So if I measure 7 millimeters, then I know I'm going to need 10 units either side. So I put 10 units either side and it'll lower the lip down by about 7 millimeters, 6.8 millimeters. How long will it last? Well, it will last for about 3 months, possibly up to 6. But I found with this sort of treatment, because these muscles get weaker, I found that after a while, I'm only doing it once a year. So for this patient that I showed you, Tanya, once a year I do it, and that's all I need. I hope that answers your 2 questions, but keep them coming. I'll keep trying to answer them as we go along. So yes, this lady was Bell's palsy, so only obviously 1 injection on one side to lower that lip. Next tip is the unsightly gingival margins. So we do get patients, that come in and they've got very unsightly gingival margins. And I'll show you this extreme case. So this is an extreme case. Now with this lady, what happened was I did implant retained bridge work for the lower arch. And the lower arch, the teeth were very loose, mobile. They needed to go. There was no waiting. And I did that. But she also has this upper arch where she's got lots of caries. And they need to go. But she was saying, could you do something for me temporarily? I just need something temporary that will make me look reasonable, just so that I can smile, because I've got my new teeth at the bottom. But what can I do at the top just to hide these unsightly gingival margins? Now, this is quite difficult because, what can you do? You can't put composite there because it's calcareous. It's too expensive to change these crowns. It's invasive to do gingival surgery. So it's very difficult. What do you do? So what I did here was I just made her a little piece of plastic. It's called a gingival flange. And it's all it is just a bit of plastic that just goes over the teeth. It just fits into the undercuts. And I'll show you, like this is her e-smile, so you can see how embarrassing it would be for her, to be walking around with a smile like that. So all I've done here is just this simple bit of plastic, which just goes over that unsightly area. And, it makes a huge difference to her. If you see the smile there, it's completely different. And all it is a bit of plastic. It took me 1 impression. I did 1 impression, took some photographs. These plastics come in different shades. So I took some photographs. I chose the shade of plastic, and I just asked my technician to make it. And the next week it was made, and she absolutely loves it. Unfortunately, she's not been in any hurry to get these teeth sorted out. So it's actually been about 7 years, and she's still got the same teeth. She's amazingly not had any problems, but she wears this all the time. I mean, it was meant just for smiling with and just for just for using when she went out, but she says she likes it so much that she uses it all the time. I'm sorry, I've just had a couple of questions, so I'll just refer to those. Excuse me. No, sorry. So you've tried lignocaine, yes? That's another way, you know, to desensitize. But you know, I mean, there's so many different methods. I mean, there's acupuncture and all sorts. But my method, you know, just with the salt, is absolutely brilliant. It works so well. Mr. Safdar again, how the plastic can change the colour. So, you know, it's a plastic, you know, your denture plastic, it's just plastic, so it just fits over those unsightly margins. So it just hides that, you know, because you can't see it. It's like a denture, but a denture flange material, which just fits in the undercut. It's very comfortable, you know, because it just sits over the lip. So the lip keeps it in place. It doesn't move around. It sort of like holds in with the undercuts. So hopefully that answers your questions. Close that off. So that's top tip about the unsightly gingival margins. The next top tip is contact point. Now, I always struggle with contact points in amalgam. Now, I know a lot of the places are not using amalgam, but this tip's really mainly only for amalgam. But yeah, I always struggled and I hated it. You know, patients would come back and they'd say, oh, you know, I'm getting food trapping. And so it was, how can I stop that happening? And Paul taught me this, you know. It's tricked with annealed metal. So what happens is a metal, the atoms are very close together on a metal. So when you push a metal apart, it comes back, it springs back, it has a memory because the atoms are very close together. So when we do our matrix band, we put our matrix band on, and then when we try and burnish it against the tooth next door, it just bounces back because it's got a memory. So what we can do is we can make the metal forget the memory by heating the metal. So if we heat the metal and then cool it down very quickly, the atoms can't come back. So the bonds, ionic bonds between the atoms have gone, they're broken. So then when we burnish the metal against the neighboring tooth, it doesn't spring back. So you get a really nice contact point. So how you do this is very simple, really. You just get your Bunsen burner and you heat it up until it's red hot. And you also have a glass of cold water or a cup of cold water ready. As soon as you've heated it to red hot, you put it into the cold water. Once it goes into the cold water, that metal has lost its memory. So then when we put it around the tooth, we tighten it and we then burnish it against the neighboring tooth. It doesn't fall back. It'll just stay in that position and your amalgam will form a good contact point. Yes, you can use it for composite if you like, but far better for composite is to use the sectional matrix, which I'm going to talk about on Thursday, you know, in my webinar on posterior composites and posterior tooth anatomy. That's going to be on Thursday, which I'll show you. But yes, if you don't have sectional matrices, you can actually use this method for composites. The only problem you do get is the matrix band does go black because it sort of oxidizes. So you just need to clean that black off, you know, so it doesn't come off onto your composite. But it is hidden, it's in that contact area, which isn't really seen very much. So I think I might have another question. Let me just have a look. Would it be difficult? I think we're back to the gingival mask. Would it be difficult for the patient to talk with? No, it's not, because it doesn't affect the tongue in any way. You know, for speech, we need our lip touching the teeth, we need our tongue touching the teeth. And so because this only covers on the labial aspect, no issues with speech with that one. The next one is how to repair porcelain. So this is what always puzzled me. You know, I mean, sticking to porcelain is going to be difficult. And it was only until I actually learned, you know, the chemistry of it, really, the chemistry of bonding to porcelain. So, you know, you get this coming through your door and you know, if we replace the veneer, it's difficult because, you know, matching again to that veneer is difficult. Patients not happy, you know, because if they've spent a lot of money on the veneer, how do you repair it? So they're never very happy. So, you know, being able to sort of repair that is always nice to have in your armamentarium. So this, I'm going to walk you through this case just to show you how I did it. And one of my rules is, if it's your own work, you repair it. And if it's somebody else's work, then you replace it. So if that was somebody else's, I would rather replace it so that, you know, I know everything's all right. But this was one that I'd done, so I'd always try and repair it. So let me talk you through this case. So this is a lady that has been seeing me for years, and she wasn't very happy with these front teeth. She didn't like the gaps. She didn't like that they were a little bit pitted and worn. So we decided, you know, we'll do some I wouldn't say no prep veneers, but prep less veneers, you know, do as minimal prep as possible, and give us some nice veneers. So we did a mock-up, you know, from the wax up. We did a wax up, did a mock-up, showed her that, you know, this is just pro temp, showed that to her. She seemed happy with that. And so the next step was just to smooth things over. You know, we took the sharp corners off, smoothed everything over, took a shade, sent all that off to the technician. Let me talk this case through. I'm getting questions, but I'll finish this case and then I'll go back to questions. So yes, where was I? So yes, we sent all this off to the technician, and then this is my completed case. She's very happy with it. I was very happy with it. But unfortunately, a few years after I did this, I think I did this in about 2013, and about 2016, unfortunately, she banged her teeth on a sink. I don't know whether she'd been drinking or she'd been fighting or whatever, but unfortunately, she had this accident with the sink. And she comes to my surgery and she said, will you repair this? Or do I have to have a new veneer? Now, obviously, this is my case, and I really don't want to replace it. I'd much prefer to repair it. But how do I do it? You know, it's my work and I want to repair it, but how? So we've got to go back to chemistry. So what we need to know is how we bond to porcelain. So first of all, when we bond to porcelain, we need to create a surface that it's going to bond to. So I'll take you through the stages that I would use to be able to bond to porcelain and do it predictably. Okay, so first thing is you need rubber dam. Okay, any adhesive dentistry, you need rubber dam, and it's you know, if you think about it, how many times do you have to wipe your mirror when you've not got rubber dam on? The patient breathes, it becomes misty every 2 or 3 minutes. So this process, you need to keep it dry for at least 10 or 15 minutes while you're doing it. It's not possible to keep it dry. It's impossible. Unless you can stop the patient breathing, you can't keep it dry, and it's not going to work. So I use this very simple rubber dam. It's called Optradam. It doesn't need any you know, any clamps, or it's not uncomfortable. It doesn't even need a frame. Everything comes attached to it. You just make the holes, you put the frame in, and you feed the teeth through. I'm not too worried about these areas, you know, where the gums, because I'm working here. I'm not working anywhere near there. But yeah, if you wanted to, you can put some liquid dam over here, or, you know, I can pull, but I just want something quick. This was done. You know, an emergency appointment. I don't have time to mess about. The patient's squeezed in between other patients. So there's a very quick fix. It doesn't take long as you know what you're doing. So rubber dam. The next thing I need to do is I need to roughen this area up, so I can bevel it or I can sandblast it, but something just to roughen it up so there's some sort of better surface to fit to. So bevel porcelain and sandblast. Then I need to etch the porcelain. Now, etching the porcelain, the only thing that can etch glass is hydrofluoric acid. It doesn't hurt you. Don't worry, it's not going to burn you or anything like that. As long as it's buffered, it will be safe. It's safe for you to use. If I got it on that gum, it's not going to kill the gum. not in the short amount of time that we're going to use it. So we need to etch that with hydrofluoric acid, but we must not etch the tooth. So if there was any tooth visible, in this case, it was all porcelain, there was no tooth visible. But if there's any tooth that's showing, then what we do need to do is we need to cover that with a little bit of liquid damp or any restorative flowable composite, anything, obviously not something that's etched and bonded, just anything that's going to be a barrier to that. I tend to use liquid damp. I just put a blob of liquid damp and stop the hydrofluoric acid touching the tooth. So this is the hydrofluoric acid that I use, which is 9% buffered. And it needs, I mean, it depends what your porcelain was. So if it was Emax, that needs to be left on for 20 seconds. If it was porcelain, then it needs to be left on for between 90 and 120 seconds. So Emax less, porcelain, feldspathic porcelain longer. So you put that on and you just wait. Obviously you can see I'm just working here. It's nowhere near here. So it's not going to cause any issues. Wait and then wash it off. You then need to wash all of that off. But when you wash it off, you'll have a powdery residue, you know, like a salt. So the next step is you need to wash that off with phosphoric acid. So you put that on the porcelain and you also put it on any tooth. So if you've got tooth, you'll flick that liquid dam off and you'll etch the tooth. So you're doing both simultaneously, which is your porcelain and your tooth. And then you wash that off. The next step is you need a coupling agent to stick to the porcelain. So what this does is the coupling agent, which is silane, will actually stick to your porcelain and one arm of that will then stick to your composite. But again, you don't want this to go onto your tooth. So if you've got tooth, you need to cover the tooth bit with some liquid damp. So once you've put the silane on, you then need to dry that. So the best is warm air. So if you can use a hairdryer, it's much better. And as you know, I don't have any need for my hairdryer, so I always have one spare. But yeah, you're gonna have to try and, or you just have to wait. You have to wait a couple of minutes. The 3-in-1 is a bit too vigorous for it. So I tend to just wait, just give it time. Also 2-bottle silane is recommended because every time you open that bottle, that single bottle of silane, that silane deteriorates. And they reckon that after about 3 or 4 months, it's inactive. And this is the most important part. This is your belt. This is the bit that couples, you know, this is what's keeping everything together. And if the silane isn't right, then, you know, it won't work. So 2-bottle silane, you're mixing it fresh. A and B, you're mixing it together and it's a fresh mix every time. So try and buy 2 bottles. I get this one from Optident, it's Bisco. And the guy that's done the most research on this is a guy called Nasser Baghi. And he's wrote over 300 papers on silane. And he's developed this product and he taught me how to do this. And it just works, you know. I've never ever had a case where I've done a porcelain repair and it hasn't worked once I've used this protocol. So I can say to you hand on heart, this does work and it's evidence-based. If you want to look up the research, it's all done by Nasser Baghi. So yes, we use the hairdryer once we've put the silane on. Then comes our bonding agent. We then apply bonding agent to that goes over the silane and we apply it to the tooth. And that's what's going to bond our composite to the remainder of the tooth. People ask me sometimes, you know, what's my favorite composite instruments? Well, I absolutely love this instrument. It's called Optrasculpt. And Optrasculpt is made by Ivoclar. And you get these little pads. And these pads are interchangeable. You know, you can buy new pads. So it's single use, but the whole handle can be autoclaved. On the other side is a flat plastic. So you can always turn it around and use your flat plastic bit. It's got a ruler. So this ruler, you know, if you want to measure the teeth to make sure that you've got them the same size, On the opposite side, it's got a golden proportions caliper on it, or measurements on it as well. And literally, it's less than £30, this handle. It's so cheap. And these bits are about a pound a go for these little silicone tips. But yeah, I love using that, because every time I put my finger, you know, I'm tempted to use my finger, but I get lipstick on it, or I get, you know, they've got a bit of, it's dirty. So, you know, avoiding the lipstick, avoiding everything, just this is brilliant. Good instrument. I'm getting more questions, but as I say, I'll just answer those in a minute. The people also ask me what my favorite polishing instruments are. So I do like this Super Snap rainbow discs. They're really good because they don't have that middle bit. You know, the Softflex discs, you have that middle metal bit, and you just about got it all right. It looks really good, and then you scratch it with that metal bit and you're back to square one. Whereas these don't have that middle bit. The other good thing about these rainbow discs is you can use them on both sides. So, you know, for areas where you can't get to it, you can actually use the other side. So I really like the Super Snap. And then these ASAP all surface access polishers, absolute game changer. You know, I absolutely love these instruments. There's only 2 discs. So you've got a purple one, which is a finishing disc, and you've got a buff one, which is a polishing disc. They're impregnated with diamond. So you get an amazing finish. You have to use them with water. So squirt a bit of, you know, a bit of water from your 3-in-1, and then you use it. They're reusable, you know, and they come attached. The mandrel and everything is one piece. So you're not having to hunt for mandrels and pop them in. They're all together. Just go straight in. Reusable. You autoclave it. So this kit, I think you get 12 in the kit. I've had it for a couple of years. And they just get smaller and smaller as you use them, until, unfortunately, you know, you've got to buy a new kit. But they're a real game changer. The other great thing is you can use them on the palatal side, because they're disc-like. You can use them on occlusal surfaces. You can get in between everywhere. Absolutely brilliant. So those are 2 more bonus tips on polishing. So that's my composite place now. Obviously, it's never going to be as good as your porcelain. You know, it's not ideal, but it does the job. You know, it fixes the thing that you came in broken with. And you know, I've said if you don't like it, we can replace the veneer. But I think I did that about 2016. It's been about 4 years, and every time she comes to see me, she says, "Nothing wrong with it. I can't see anything wrong with it. I'm really happy." And that's, you know, that's after the repair, you can see, and that was before the fracture and after the repair. Yes, of course, it's never going to be the same, but it solved a purpose for me. So obviously the thing is with this, there are going to be differences to this technique. So like I was saying to you, if the tooth is exposed, then you have to cover with liquid dam. Don't be putting hydrofluoric acid on it, you know, because hydrofluoric acid will affect the bond. You can use opal dam or liquid dam, anything that will just block it, and you can easily flick off. You know, you can use like you know, that temporary filling material that you use in inlays, you know, the clip stuff, or Systempon, like anything that's just going to form a barrier. Even a piece of PTFE tape, just placed there, as long as it doesn't touch. And then, you know, when you put the hydrofluoric acid, when you've removed that and you put phosphoric acid, then you want it on the tooth. Remember to remove, that will remove the salt and etch the enamel at the same time. Silane porcelain, but don't touch tooth. Again, you can't put silane on to the tooth, so be careful. Cover the tooth. Other steps are the same. Then what if we've got a metal ceramic crown, you know, where we've got metal showing. So there's a slight difference in the technique there. So again, with the metal, you need to sandblast it. You can't, the hydrofluoric acid won't do anything to that. So you need to sandblast the metal, but obviously you sandblast the metal and the porcelain at the same time. So that's one thing you're doing anyway. You cover the metal with the liquid dam, and you use hydrofluoric acid to then etch the porcelain. You don't etch the metal, no need. Phosphoric acid you can do on both. It doesn't matter. It's not going to do much to the metal. You can keep the liquid dam on if you want. That doesn't matter. As long as you get rid of the salt. Somebody's raising their hand. 1 second. Let's see if I can look at that. Which composite can you use? Any composite, whichever composite you have. It doesn't matter. It's composite. You can use you can use a you can use you know, a microfill, hybrid, whatever you want. My favourite for this one is the Venus Pearl because it's strong. It's aesthetic, but it's very strong. So I like to use Venus Pearl, but it doesn't matter. It's just composite. It's just anything that's going to fill the hole that's the same colour. One other tip I'll give you, I tend to rehearse. You know, what does an actor do before he goes on stage? He rehearses. So I'll get my different composites and I'll try little blobs of them onto the tooth to see which one matches best. So before I've etched, before I've bonded, I'll try them on and flick them off and say, right, okay, that's the one. That's the one that I like the best. So even the same shade in different composites looks different. So, you know, I just try and then see which one looks best and I use that. So yes, any composite. So going back to this, sorry, I've digressed. So yes, where was I? So you sandblast the metal, you cover liquid dam and hydrofluoric acid etch, phosphoric acid, remove liquid dam. Now on the metal, you have to use a metal primer. So Z Prime has got a metal primer. So you can use Z Prime, or if you look in your Panavia kit, it used to be called alloy primer. So you can use that primer to prime the metal. That's like the silane for metal. It's the coupling agent that bonds to the metal. Now, unfortunately, Panavia have changed the name of that bottle to ceramic primer, but it's actually got the 4-meta, you know, what you need, or what's that protein called? It slipped my mind. But it's got that that protein that bonds to metal. So although it's called ceramic primer, if it's from the Panavia kit, you can use that. It is actually an alloy primer, and it's got the 4-meta in there that you can use. So then you apply the silane to the porcelain. You don't put the silane on the metal. It only goes on the porcelain. Here you need special composite because you need to opaque it. So you need the very white composite. It comes in a tint. It's like a, it's in a bottle. It's like flowable composite. It's very white, and you just need to apply that over the metal to hide that metal from showing through. And then the other steps are exactly the same. You apply your bond, you put your composite on, polish it. I hope that makes sense. So it's just knowing the chemistry. And again, I've got a friend of mine who had a parachuting accident, and I had to make him this bridge, and it's an 8-unit bridge, and it's been in for maybe 25 years that this 8-unit bridge has been in. And about 6 or 7 years ago, he chipped the front one, and it's porcelain bonded to metal. And I repaired that with this technique, and still going strong, because I don't really want to replace the bridge. It's in good nick still. So it's a really good technique, and it really does work. Got another question, see if I can just answer that. What is liquid dam? Okay, what is liquid dam? So liquid dam is something which you get, you know, in whitening kits. So when we used to do the Zoom whitening, you had to protect the gums with a liquid dam. So you put it onto the gum, and you cured it with your light, and it just formed a barrier. It just sticks to the gum, so it's just like it's a liquid that you place over and cure it. It's light cured. I don't know if it's not available everywhere, but there's lots of things you can get just to block it off. You know, there's that you know, the stuff you use around rubber dam. You can it's like a cork material which you use around the rubber dam. You could use that. You could use like a cavet temporary filling material. All I'm saying is you just need a barrier to stop the etch from touching that part of the tooth. Or you can just use a very, very thin tip, you know, and then just avoid getting it onto that part. That's okay as well. So we move on to our next topic, which is placing retraction cord. Hold on, just before I start that, I've got another question. No, I think I've answered that one, the liquid dam one. Placing retraction cord, again, I really struggled. You know, when I put a retraction cord, it was so, I put one bit in and another bit would come out. Patients found it uncomfortable, and I used to avoid using it, you know, because it took me so long to do it. And then thankfully, Nasser Baghi again, you know, I've learned a lot from this guy. I was very fortunate because he taught me on my MSc, and then I started teaching on that same MSc that I did. And so I had lots of opportunity to learn from him, and while I was teaching with him, because he came back every year and he had new things to share with us, and obviously sitting around the table, at times I could ask him things. So I learned a lot from him, as I have from Prof. Paul. You know, these are the people that have really helped me in my career to learn things which have helped me throughout. And this was one of them, which was placing retraction cord. So this is Nasser Baghi's method. So what Nasser Baghi explained to me was that the bit in between the teeth, the interproximal areas, there's a lot of gum. You know, there's like 5 or 6 millimeters of gingival tissue there. So the logical place to start putting retraction cord is in between the teeth. And what he said was, if you use it like floss, so cut a bigger piece, you know, cut a bigger piece than you normally would, and stretch it. Obviously have it wet. Always have retraction cord moist so that it doesn't damage the tissues. You stretch it, and then you floss it. You floss it in between the teeth, and then it'll stay, you know, because it's already quite deep in there. So it'll stay, you can let go. Then you just bring it round and floss it through the other interproximal area. Again, it's gonna stay in that area. So what you've then got is, you've got tooth, you've got retraction cord all the way around, and 2 ends. So what you then do is, the 2 ends, you pull tight. And also, at the same time, with your flat plastic, just direct the floss, labial it upwards. So when you push, the floss goes upwards. It's already in interproximally, and then it just automatically places itself labially. So within like within 10, 20 seconds, you've got it in 3 areas. You've got it in labially, you've got it in interproximally. Then all you've got to do is, you've just got to tuck it in palatally. So then you use your flat plastic or your retraction cord instrument to just tease it in between palatally, and then you cut the end off. And it makes so much sense, and it makes it so easy to do just by doing that method, rather than trying to, you know, we always start labeling, and there's not much tissue there, you know, so you're pushing it and then it pushes out. Then you push it here, it comes out, and it's uncomfortable. But just think, you only have to position that one part, that side, and you know, it makes it very, very easy. So that's something which has really helped me. But still, you know, if you don't want to use retraction cord, this is another game changer for me, is Expasil. I don't know whether any of you use it, but, you know, in certain teeth, you know, in certain cases where you've got a very thin biotype, I really don't want to be putting retraction cord in. Then I use Expasil, and all Expasil is, you just squirt it in between the gingival margin and the tooth. And what it does is it expands. So it expands, and it also stops all the bleeding, because it's got a chemical in there that just stops. Thing is, a lot of people use it and don't use it properly. So you've got to know how to use it. So you squirt it in, you know, quite, you need a little bit of force. So it just does go in between the tissue. You force it in, and then you get your cotton wool roll, and you just, you know, push it with your cotton wool roll, and then you have to wait 4 minutes. This thing needs time to expand. So this is where people go wrong, because they don't wait 4 minutes, because dentists don't do waiting. You know, we never do waiting. You know, we're so impatient. We want to get the next patient in. We want to have our coffee break. We don't wait the 4 minutes. So you do need to time yourself, you know, time yourself and wait the 4 minutes. And then all you do is you just wash it off. If you wash it off, you'll have no bleeding, and the sulcus will have come away from the tooth, because this will have expanded the sulcus. But you have to be quick with your impressions because obviously it'll come back, you know, it'll come back within a couple of minutes. So be quick, get your impression done. And that's another game changer for me. Downsides, it's expensive, you know, Expasil, it's expensive. But for me, you know, I just charge an extra £5, you know, for patients will pay a bit more knowing that they're going to get, I mean, I don't say I've used Expasil, so it's going to be extra £5. I just know from the case that this is thin biotype case. I'm going to be using Expasil, so instead of 495, it'll be 499 for your veneer, you know, and it pays for it. It's, you know, at least just think as well, if you have to do another impression, how much is that going to cost you? A lot more than a little bit of Expasil. So, you know, sometimes it's penny wise and pound foolish. It's better. Don't scrimp on materials. Just do a good job. It's so much better. So that's my tip about let me just check the questions because I know there was one there. What are the roles of retraction cord apart from stopping the bleeding? Well, retraction cord pushes the gingival tissues out of the way, so you get a much better impression. So the impression material goes beyond the margin, so you're going to get some flash. How much do you charge for the porcelain repair? Me, very little. You know, if I've done the veneer, then I don't want them spending money. I think that one I did free of charge, but maximum I've charged is £50. It literally takes me, you know, 10 minutes, 10, 15 minutes, not long at all. And like I say, it's predictable, but you can charge what you want. I mean, if it was somebody else's work, you could charge a lot more because, you know, that's worth them having to have the whole veneer done. And like you say, or like I was saying, to be accurate, it may not match again, you know, and it's a lot to go through. Imagine you'd have an hour drilling that off. You'd have, you know, another visit. You'd have a temporary one in that time. So to the patient, that could be worth quite a lot more. So you could charge £100, 75. I don't know. I'm not. I'm very cheap. I don't overcharge. So, you know, I'm not the one to ask about fee setting. Right. Okay. Right. Where are we? Yes. Predictable non-vital bleaching. So, non-vital bleaching, again, this was another thing, you know, which, you know, patient comes in, you want to do a veneer, but you know that you'd have to make the veneer very thick because the tooth will shine through. So I wanted to know how to do non-vital bleaching predictably. And thankfully, you know, part of my master's was so 6 weeks we spent studying bleaching. And I learned how to do it properly. And now, you know, when a patient comes in, I can say hand on heart, this will work. As long as you follow this, it's going to work. So it's being able to do this for a patient, you know. So this patient, we got from that to that within a weekend, you know. So this is what she looked like on a Friday, and this is what she looked like on a Monday. So I'll go through my technique, how to do it. It's extremely predictable, you know. The one thing you need to know about with bleaching is that the bleach only works for a few hours. So if you've got 10% carbamide peroxide, which is the one that's recommended, mostly tried, trusted, and it's going to have the least damage to the teeth, or, you know, the least chance of root resorption. So what you need to know about this is it goes like this. So it doesn't work for about 2 hours. So 2 to 4 hours, it's working most, and it stops working after 6 hours. So you need to catch that time between 2 and 4 hours is when it's doing its most. And obviously if you can carry on a bit longer, that's fine. But if you're calling the patient every week to have that changed, they've only had 6 hours of bleaching in that week. So it's going to take you weeks and weeks to do it. The patient's going to lose interest. You're going to get a bit dejected thinking this isn't working. So the way to do it is this way. So let me go through it with you. So obviously, first thing, you've got to make sure that the root treatment is good and there's no apical area and, you know, everything's sound. We take that as a given, you know, that you do all the groundwork and make sure that the tooth is healthy enough to do the bleaching on. You then make whitening trays. So you take impressions so that you've got the trays. You don't need reservoirs or anything like that, just simple, basic whitening trays. Then what you need to do is, so this would have been done all beforehand. Then you ask the patient to come and see you on a Friday. Now, if you're in Dubai, I know the weekends are different. Just imagine your weekends are Saturday and Sunday. But in Dubai, you might have them come on a Thursday and Sunday. Just modify it to how you do it. But in the rest of the world, you know, we have our weekends on a Saturday and Sunday. So I would see the patient on Friday. I remove the composite from the access cavity. I also remove GP to below the CEJ. So with Gates Gliddens, I'll remove quite a bit of GP, leaving myself enough to place 2 millimeters of GIC. 2 millimeters of GIC, the research shows it's important. That will stop root resorption if you've got a minimum of 2 millimeters of GIC. But that GIC needs to be beyond the CEJ because the bleach needs to go to below the gum margin. So you've taken GP down quite a bit, you've got at least 2 millimeters of GIC, and then you've got an open access cavity. Keep that access cavity open so that the patient can put the bleach. So you give them 1 syringe of bleach. You then instruct them to put their bleach, 10% carbamide peroxide, into the access cavity. They put that in, then they get some into the tray itself on the, obviously the labial aspect. So they're getting bleach going from outside and they're getting bleach going from inside. They then put the tray in. Now you could mark across if you want, if you've got somebody with very few brain cells, like most of my patients, you could mark across on the tooth where they need to put the bleach so that they don't put it on the wrong tooth. Or you can cut the bleaching tray so that, you know, they've only got the 1 tooth and the rest is all cut out. You can do either or. I just mark it for them. Bleach goes inside the tooth, bleach goes in the bleaching tray, and they put it in and they keep it in. Now remember, the magic number is 2 to 4 hours. So they go on, so just reading through this is what I've said. The other thing, give them some micro brushes, you know, the things you use for your etch, you know, those little brushes. Give them a few of those to be able to clean the tooth, you know, because it's got an open access cavity. So they're going to get food going in. So give them some of those. So the magic number is 2 to 4 hours. So what they do is they go home Friday evening. They've got to leave it for minimum 2 hours, ideally 4 hours. So in the evening, they've left it for 4 hours. I mean, they can easily do that, 7 to 11. Then clean it out, they go to bed. When they go to bed, they put it in again overnight. So when they're leaving it in overnight, they've got a whole night's worth of whitening. So already by Saturday morning, they've had 2 whitenings. They do the same on Saturday morning, 4 hours, 3 hours, whatever they can do, minimum 2 to 4. They do that Saturday morning, Saturday afternoon, Saturday evening. They sleep in it for Saturday night. So there's 4 applications there. They've had 2, had another, so they've had 6 goes at whitening. That then comes Sunday. Sunday they do the same thing, sleep in it Sunday night. So they've had another 4. So that's 10 tooth whitening applications where they've kept changing it over a weekend. So when they come to see you on Monday morning, it's bright. It's brighter than the other teeth. So if they wanted to brighten the other teeth further, they could do. But that's predictable. And it's done over like a weekend. So nobody loses interest. Nobody's thinking this isn't working. You know, I need, keep coming back to the dentist, keep changing it. And, you know, you're not going to damage the tooth in a weekend. They're not going to. So, but yes, it's important then when they come and see you on Monday that you put some temporary dressing in that. So all these appointments are booked as soon as the patient comes to see you. You must make sure that you're in. You're not on holiday on the Monday, and you're not, you know, or patient's not on holiday. All these appointments need to be booked in. So at that time, you put temporary dressing in. You don't put proper composite in. You can't, because the research shows that it doesn't bond. You know, when you've got oxygen in the tooth, because obviously the tooth whitening releases oxygen, it won't bond. So bond is 25% less if they've just been bleaching. So you just put temporary dressing. I just use Cavit. You can use, you know, I don't know, GIC. GIC is just harder to remove, so I just use Cavit. And then 2 weeks later, when they come back, you put a very white composite, the whitest composite you've got, so that it keeps it white from inside. Now, you must remember that this doesn't last forever. Those toxins that are in the non-vital tooth will eventually come back. So after about a year or so, they need the process repeating. So if they keep the trays, then all you need to do is open that access cavity up and do the same weekend thing. And I just charge for a filling then. They don't need a lot of bleach, you know, they usually have some left over, or if they haven't got some, you can always sell them a syringe of bleach as well. And that's very predictable, you know, and certainly I like to do that anytime I'm going to do a veneer. I like to have the tooth that I'm working on white like the other teeth, so I'm not having to hide the color discoloration. So now we're on to, we've not got long, I don't know how long it's taken. We have gone on longer than I'd expected, but don't worry, we don't have that much longer. So the next one is recording RAP. So this was one, you know, it takes a lot of skill to record RAP. There's so many methods, you know. You've got the method with the you know, the gold standard, where you've got to manipulate, and then you've got to then make sure you find that RCP position. Then you use wax to record it. Quite difficult to do, you know, especially for a novice or somebody with limited capability like myself. So there's other ways. The AFR is good. You know, it's one of these devices that you put in and you trace. It's like a Gothic arch tracing, but you know, it's expensive. And you know me, I don't like to spend too much money when I can find a cheaper way of doing it. So the AFR. I know we've got questions, but I'm just going to do those at the end now, because otherwise it will keep you late, and I don't want to keep you longer than I have to. So I'll answer those at the end. Hopefully I'll get through them all. So AFR, yes, it's you know, it's more expensive. Green stick is good, but it's the same thing. You got to know, you got to manipulate, and you're never sure. Lucia jig's great, you know, it's tried and tested method, but with Lucia jig, you know, you get high on the Duralay, and it's a bit time consuming, and it gets warm on the patient's teeth and stuff. So another very easy method is a leaf gauge. So I've got a leaf gauge here, and I'll try and show you. Ideally, I'd like to demonstrate on a patient, but it's not that easy. So a leaf gauge is this. And what a leaf gauge is, it's a device used for measuring clearance. You know, so if you wanted each one of these is 0.1 millimeters, you know, the thickness. So if you wanted clearance of 1 millimeter, you put 10 of those together through your crown and see if you've got 1 millimeter. If you need 2 millimeters, then 20 can go. So that's what they're used for. But they're very, very good for finding RCP and for recording RAP. So all you do is you get these and you put it, and you get a patient to go hug and that, hug and that. When it's back, difficult for me to speak and show you at the same time, but I'll try my best. So when it's in the back position, like that, that's RAP when it's in its back position. Take off, leave until you can see the first point of contact, or the patient says that they can feel that point of contact. When they can feel it, you know that that's RCP, and you jot it down. And you can also check it with bimanual manipulation to see if you've got the same spot. Anyway, when you've done that, you go, you can then squirt, keeping the leaf gauge in position. Squirt bright red material on both sides, so the leaf gauge is in position. It stays like that. Put the in this side. Wait for it to set. Once that's set, get them to open the mouth. Take the leaf gauge out, but those back pieces still stay. squirt bite reg paste to join it up. So what you've done is you've got a recording of, in bite reg material, you've got a recording of RAP. And it's very simple to do, it's very predictable, and it just works, and it's so straightforward. I'm sorry, it's probably not going to be as good as, you know, me demonstrating it in real life, but I hope one day I get to see you all and to be able to show you myself. So that's my tip on predictable recording RAP. I hope that makes sense. The next one is how to do predictable alginates. Now, alginates, difficult. Well, you'd think they're easy, but don't forget, alginate, if we get the alginate wrong when we do our opposing bite, it'll be wrong. One air blow is going to spoil the articulation. How many times do we get crowns and we have to keep adjusting them? Or we get a denture and it's not right? A lot of the time it's because we've not done our alginates properly, or we've not followed the correct principles. So alginates, I'll show you how to do predictable alginates. So first of all, stop using the disposable trays, you know, the perforated disposable trays. They're no good, you know, they're not going to do the job. A couple of reasons. You get air going in, you know, because you've got perforation, so you're going to get air going in. And the enemy is the air. Second thing is, you need adhesive on those. Now, adhesive takes 6 minutes to dry. We are never going to wait 6 minutes. We can't wait 4 minutes for our Expasil. Who's going to wait 6 minutes, you know, for a adhesive to dry? Nobody. So it's always coming off our trays. When we take it out, little microscopic areas are coming away. The alginate is never going to be correct. So in a rim lock tray, it's a metal tray with no perforations, and it's got like a little rim that the alginate locks into. So there's no need for fix. So, and it can't come off. There's no way that the alginate can come off or come apart. It will just stay in. These trays are autoclavable. They are next to nothing, probably £4 or £5 for a tray. And you only need a couple of sets. You know, you're never gonna need more than that really. A couple of sets of these, you autoclave them, and you know, that's the first thing I'd recommend you buy. The water needs to be at body temperature, not room temperature, not cold. It needs to be at body temperature. So you need to mix hot and cold water together, and when you touch it and it's not warm, not cold, just wet, that's the correct temperature, that's body temperature. So you need to keep it at body temperature. You need to mix it with minimal air blows. So an alginate mixer, you can buy this alginate mixer off eBay, literally 60, 70 pounds. But that alginate mixer, it mixes it itself, it just turns and the nurse just holds a spatula. That shows that there's 40% less air blows if you have an alginate mixer. Use that, get one from eBay and use it. Other thing is to butter the alginate. So what you do is, nurse is mixed, I get a little bit on the back of my hand. While the nurse is loading it into the tray, I then get it on and I just butter it onto the teeth, the outside, the biting, and the inside. Just butter it all over. That way, the alginate is you've taken out the air blows and it's closely fitting to the teeth. Or if you're doing a denture, put it on the palatal, put it in the retromolar areas, put it in the sulcus, you know, where you need the most detail. But use your things while the nurse is loading. When the nurse is loading, now another thing, do this in a 45-degree angle. Don't do it sitting up because you can't see. If the patient's lying back slightly, you can see, you can get round, you've got more access, and then hold the tray. Don't let it bounce. You've got to hold the tray, support it. Do all your border molding. One hand supports, one hand does all the border molding. Next thing, when you take it out, you have to put it in the right way around. A lot of people, or most people that I've come across, put the impression in the tray, in the disinfectant, the wrong way around. It shouldn't go trays down, it should go impression down, because what happens is the heels then can start coming away and distorting. So put it the right way around, or chop the heels off. If you've got a knife there, chop the heels off, then it doesn't matter which way around you put it. The other thing is to cast it within an hour. Ideally, if you can cast it within an hour, then you know, it's going to work. It's not going to distort. Use good quality stone. I see so much cheap stone chipping away. How can they, you know, when the technician's trying to do his, you know, articulating the cast, it's a chipping off. How can you ever get a good, good crown? So buy some good quality stone, give it to your technician. It's for you, it'll be cheap, but for him, because he's doing so many, he's going to look and find the cheapest one. So if you give him a bag full, might cost you 50 quid, a bag full of stone, just use that for mine, then, you know, he's going to be using it. So always, you know, think ahead. I'll be quick with the last couple. So crown bite registration. Now, again, you know, bite registration, the best way to do the bite registration is prep only bite using Durolay. So if you mix some Durolay and put it on the tooth that you've prepped and it just goes in, that's your best, most accurate bite reg material that you can get. You must, on the bit that's on the buckle, you must put the tooth number and the surface, write it in, because the technician won't know which way around it goes. So you've placed it and you've got a little bit that comes out the side. You just label it, put lower right 6, B for buckle, and the technician knows. The other good thing about that is you can use it to hold the bite. So let's say you're doing a whole quadrant, there's a chance that you could lose the bite. Or let's say you've got one side and you've done one side and you don't want to lose the bite when you do the other side. You can always use those bite reg. It will never lose it. You'll always keep it in position. So Durolay, because it's such a nice, stable, rigid material, if you prep 6, you've done the bite reg for the 6, you then do the 5, you can keep that in place and keep checking the bite and it won't go anywhere. It stays. And same if you're doing the 4. So when you're doing quadrant dentistry, always use these prep only bites with Durolay. Absolutely brilliant. Difficult to explain, but if you come to using it, it's not rocket science. You just mix it up into a putty, pop it in, get them to bite on it, and that will then stay, label it. You send that to the technician and he can place that, and it's very, very accurate. With bite reg material, because you've got it all over, patient can bite to one side or the other. It's a bit of material in between, stops teeth going together, whereas this only goes over the prep tooth, so it doesn't go over the others. Right, and the last one, last top tip is prime speak. Now, prime speak is a way of communicating with your patients, and it's absolutely brilliant because it's founded by an Australian dentist, Michael Cernick, and he uses metaphors, you know, to talk to patients in language that they can understand. It's so good because, you know, I used to find it so difficult to convince patients. I couldn't work out, for example, if I told a patient that they need a filling and it costs £60, they'd spend the £60, they'd come back for their appointments and spend the £60, no problem, they need a filling, I'll do it. But if I said to the patient, you need to see a hygienist and it's going to cost £39, but that's going to help all the teeth. It's not just helping one tooth. I could never get them to come back. You know, they had to say, oh, well, I couldn't be bothered. And that was because I wasn't communicating everything properly. And I'd recommend this course. You know, it's really good because it shows you how to explain to patients using metaphors. So one of them is abfraction. You know, I could never understand abfraction. I could never explain to patients, you know. So you get a patient that comes in, they've got a little bit of, you know, abrasion here, which is usually abfraction. And you know, what do? You put your composite on and sort of 2 weeks later that falls out. And patient thinks you're a really poor dentist because, you know, your fillings don't last. But the last dentist, when he did fillings, they lasted forever. But it's abfraction, you know, and so you can explain it. And how Prime Speak explain abfraction is, if you imagine you've got a Mars bar, you put the Mars bar in the fridge, you then get your Mars bar and you do this. What happens to the chocolate? Well, the chocolate flakes off, doesn't it? So on your tooth, this tooth here, you've got a non-working side interference. And when you're clenching and grinding, that's then causing that tooth to flex like your Mars bar. And your enamel is the chocolate and it's just flaked off. And so if I put something else there, the same thing is going to happen unless I address the non-working side interference. So just being able to explain something to a patient in simple terminology meant that I could understand it and I can teach it to students. You know, I can go to a student and explain abfraction using a Mars bar. And so it's just using, and they have metaphors for everything, you know. So I can just explain things to patients much easier. So for example, periodontal treatment. Why do I need to say the hygienist? I clean my own teeth. You know, what's she going to do? So again, how they explained it was, it's like a splinter. If you have a splinter in your hand, that splinter you can't get off. You know, you can clean, you can do everything. And eventually that's going to get infected. So that splinter needs removing and it needs something to remove it. So the hygienist is going to remove that splinter. When that splinter's gone, your skin and your gums can heal. If we don't remove the splinter, that's going to keep getting worse and worse. So it's important that we do that. Now, I won't go into it in great detail, but they go obviously into more detail about the whole gum disease thing. But I'm trying to explain to you is how they explain using metaphors. Another one is, you know, you've done an endo on a posterior tooth. Why does the tooth need a crown? And again, it's difficult to explain. You know, they just think, well, he just, now he's made his money on the root treatment. He wants to make money on the crown now. So they start getting, you know, the wrong idea. So it's very easy the way that the prime speak explain it. What they say is, look, it's like a leaf in autumn. What happens to a leaf? You know, in a leaf is moist normally, but in autumn it becomes dried out. It becomes brittle. So what happens in a tooth, when I've removed the nerve, I've also removed the blood supply. When you've had your root filling done, I've removed the nerve, I've removed the blood supply. So the tooth has dried out. So the tooth is more brittle. Also, there's a big hole that I've made to get to the root filling. So the tooth is much weaker because it's a hollow structure that's dried out. The other thing is I've also taken the nerve out of it. The nerve tells my brain how hard I'm biting on that tooth. So because your proprioception's gone, you'll bite harder. Because you bite harder, 25% harder than you would on your other tooth, this tooth is already weak, it's already dried out, and it's got no blood supply. You're going to break it because you're going to put more pressure on that tooth because you don't know. It's like when you're asleep, when you bend your finger back, or you lie funny because you're asleep, you don't know it's done, and then it hurts. Like that, because the nerves are gone, you're going to bite harder on that tooth and it's more liable to fracture. So to protect the tooth, we need a crown. And if we don't do the crown, the chances are that it'll fracture, and the research shows that. So it's just a nice, easy way of showing a patient using metaphors why they need the crown. And I've been able to sell a lot more dentistry by using this terminology, you know, and just making it in a way that patients can understand. And the last one was, why is the second bond no good? You know, you do your composite, it fails. Then you do it again and it never works. You know, they'll say, oh, I've had this one done, it's lasted 15 years. And they come in and you do it and a few weeks or a few months later it debonds. And why is that? You know, well, we know, don't we? We know that, you know, the enamel tags have been used up and the second bond is never going to be as strong as the first one. Same when you stick a Maryland on. First time you've stuck it on, it's lasted years and years. It comes off, debonds, you put it on again, it won't last as long. But it's hard for a patient to understand that. So the first thing I say to the patient is, look, this is the second time this is being done. It won't last as long. Reason is it's a bit like sellotape. You know, when you stick sellotape for the first time, it sticks really well. If that came off and you stuck it back, it's not going to last as long. And the reason is because the tags have been used. You know, whatever sticky adhesive surface was, a lot of that has gone missing. And that's what's happened when it's debonded. So lots of those enamel tags have been blocked by that first adhesion. So the second adhesion will not be anywhere near. And the third and fourth, you know, you may as well forget it. We need to grind a bit more down and do a new one. Or, you know, take a little bit more tooth tissue so we're down to the next layer. And so, you know, that's just a bit about prime speak, just to be able to explain to your patients, you know, why in a bit more clarity. So we've got to the end of Ash's top tips. I hope you've enjoyed some of them. I've got lots more, but I know, you know, I've kept you a lot longer than I thought. You know, I went in a bit more detail than I'd expected to. Now we have got questions and answers. Right, so let's start with the first one. How do we burnish the matrix band once placed in the mouth for good contacts, as you mentioned earlier? Very simple, you just get a burnisher, you've placed your matrix band on, you put your burnisher on the side where the cavity is on the matrix, and you just burnish, and it'll just stay there. You just burnish it to the tooth next to it. What is GIC? GIC is glass ionomer cement. I'm sorry, I should have meant. So glass ionomer cement, chem fill, Ketac fill, what else is there? You know, the one in the gun. Any glass ionomer is glass ionomer, GIC. We use so much GIC now in the UK with our new contract that we've abbreviated it now. It's sodium perborate, yes. Sodium perborate, yes, it is. There's more risks with that. We can't get it here anymore. And because you know, carbamide peroxide is so predictable, it doesn't cause any harm. It's you know, less chance of resorption. If you can get sodium perborate, you can use it, but I wouldn't recommend it. I would just use, and you have to mix it. So you'd have to use it as the walking bleach. So you'd put it in, and then you have to get the patient back, drill out your temporary filling, put another bit in, and it goes on for weeks and weeks. So it's just no, you know, it's no good. I would go with carbamide peroxide. Yes, so Maxine, thank you. Got a great tip for internal whitening. You do have to do it about once a year, once every 18 months. Just the same exactly, you know, just a weekend. Get them to, yeah, so Maxine, you just answered right. What happens if you bleach and then crown? Yeah, I tend to, with the ones that have non-vital bleached, I don't crown them. I usually leave the palatal side. You know, I either do like a 3/4 crown, or I do a veneer, or I just don't do it. Or if I'm gonna do a crown, then I just do PFM, you know, and then don't bother with the non-vital bleaching. It's more for those cases where I know I can leave that access cavity open. Is GIC removed when the, no, keep that GIC. That's a good barrier. Keep that GIC, don't remove that. What is the full form of RAP? So RAP is the retruded axis position. So when we were reorganized, we work in retruded axis position. This is the most comfortable position for the jaw to be in. And it's reproducible. So we need to be able to work in that position, or at least to have our study models in that set in that position. So that's what RAP is. Maxine, thanks so much for this webinar. Tips make all the difference, and thank you for sharing what you've learned from years of experience. I know it's not part one of your topics, but I'm really struggling to wear my loops with my light and PPA. So frustrating. Oh, tell me about it. It's impossible, isn't it? I'm struggling, you know. Apparently you can buy a visor. Optiloop do it, which is I've got the space for the loops, and that's my recommendation. Or get a hood. If you've got a hood, you can work through it. But yeah, it's nightmare. It's COVID. How do you basically put the Duralay on? Only with a punch arm? Okay, there's two ways of putting the Duralay on. You can do a bead-on technique, so the patient stays open. You've got three things. You've got your liquid in a pot, you've got your Duralay in a pot, and you've got your tissue. Dip in liquid, put it in powder, put it onto the tooth, wipe with tissue. Liquid, powder, tooth, wipe, and you keep beading it on, build it up, and then you get the patient to bite into that. That's one technique. Second technique, you get the liquid, add the powder, you mix till it's in like a putty stage, you roll it up, put it over the tooth and get them to bite into it. And that's it. Either way works, whichever you want. Only a very small amount. You only need enough to cover the bite bit, and a little bit to go over the label aspect so you can label it and for it to link up. Tiny, tiny amounts, not a lot at all, just a small amount. And that's your bite record. It's very stable. It's really, really good technique. Something you've got to try, and it's not ideal for a webinar to be able to show you. I can show you on a phantom head, or, you know, I mean, it'd be lovely if some of you do these courses. I know a lot of you probably have done, but we can show you these things in person, or maybe we'll make some videos on it. No. So do you take the bite reg is after you've prepped that tooth, that single tooth you've prepped. It's to record the bite for that. It's called a prep only bite. Please, can you repeat the leaf gauge? Yes, of course. Leaf gauge. So you get lots of leaves. Put it in between the front teeth. Angle it about 45 degrees. You get a patient to go forward, forward and back. When they're at the furthest back they are, that's RAP. That's the most furthest back that they can go, which is what you would manipulate. So forward and back. And then if you remove leaves, you can see then when it contacts. So you can see the RCP position. RCP is the retruded contact position, which is the first tooth to contact in RAP. So you'll be able to see that. That's only for you to know and to note down. So you know where that position is, because if you were going to reorganize and adjust that, you need to know where that is. And so does the technician. So when he closes up the pin, he can see that that's accurate and it loads up. So once you've done that, and you can keep enough space for some material to go in between. So you put that in, you go forwards, back, and then you squirt. Bite reg material. You'll only be able to squirt bite reg material on the back teeth on both sides. So you squirt it in at 90 degrees and you let it set. Once that's set, patient opens, you've still got bite reg material on those back teeth. You then join that up, join that bite reg material up with some fresh, change your tip, fresh bite reg material. And then when they bite together, the back bit will guide them, because they've only got the indentations, will guide them into that RAP position. So they'll automatically bite into that back position. And this front bit will get joined. So you'll have a single piece of bite reg material, which you can send to the technician. He will then mount his upper model using your face bow, and then he'll put this bite reg record, this RAP record, onto the front, and he'll locate the lower model into that, and then he'll mount it. So you will get upper and lower models mounted in RAP using that record. And it's very simple to do. I don't know whether I've been able to show you that clearly or not, you know. When using these guys, what thickness do you use? So you use as thick as you need to. That's why, you know, the leaves you can add or take away. So if you put too few in and the teeth are hitting, you can add more. So you need to make it so that the teeth are free to move and enough room for the bite reg material to squeeze in. The closer together it is, the more accurate, but you need enough space to put the bite reg material in. But that's why you need leaves, so that you can add and take away. Excellent practical. Oh, thank you very much. You'll do. Practical, well, it's not easy under these circumstances, but I hope that's helped. Nikki, thank you. I'm glad you like what we do. When do we check RAP? Not sure I understand the question. When do we check RAP? I don't know, Fatima. I really don't understand the question. Thanks for the webinar, Dr. Ash. Love the tip with the leaf gauge and the detailed bleaching steps. You're welcome. Thank you. We will like to have one presentation of RAP demo. Okay, I'll feed that back, and you know, we'll do that. We do have some videos. You know, when we do our course, we have videos on all these techniques, and it's properly done on a patient, so you can see it more clearly. But you know, I think it's just something you might have to sign up to. Shaista, oh, you're so kind. I'm glad you understood the tips. Oh, Fatima, you understand now. That's brilliant. So I think that's all the questions dealt with now, Lou. Let's see, there's something that says more. I'll click on that. Chat. There's some more. Oh yes. What do you use to take the impressions for the gingival flange? Just alginate, basic, straightforward, just alginate, nothing complicated. Do you use one matrix band to pack the amalgam initially and then heat and cool? Oh no. You heat and cool first. That same band, hot flame, cold. It's cold, so it's not going to burn the patient. You put that in, you burnish it, and then you pack the amalgam in. No two, it's just one matrix band. It's dead straightforward. It won't break the amalgam. No, you've cooled it down. Nothing happens to the amalgam. It's a leap of faith. You're just going to have to try it. It's amazing, Venetia. Just try it. It's one of these things which in industry they use a lot. This is how they bend metals. You know, they heat it up. They cool it, they bend it, they cool it down, and it stays there. It's just something they use in industry, but you know, and a lot of dentistry is engineering, you know, but we just find it a bit difficult to get our heads around. Right, I didn't quite get exactly the contact points technique. Can you repeat, please? I don't think I can keep repeating the same thing. I think it's something which you're just going to have to try yourself. All it is heat it up, cool it down, use it as you normally would, but burnish it and it'll stay against the neighbouring tooth. For the plastic denture, how much would you charge? I charged £150. I think the lab technician charged me about 20. It was 2 visits, impression, fit, 2 visits, a few photographs. But don't think I'm cheap. I'm not your most expensive private dentist. You charge whatever you want, you know. Is this just a temporary solution? Well, really, yes, it was. It was meant to be a temporary solution, but I don't know whether you could call that 7 years, you know, a temporary 6, 7 years. It's been. Right. Just can you finish your course first and then yeah, okay. What do you call the instrument? What's one other thing? It's called an Optrasculpt. Optrasculpt. Can you share some product names for Liquid Dam? No, I mean the one I use is called Liquid Dam. That's the product name. I don't know any others. Sorry, I didn't follow. What do we give them on Friday evening? They have the tray. They have both. They have the tray to put the bleach in, and they have the bleaching solution. So they put the bleaching syringe. They put it into the tooth. With that same syringe, they put it into the bleaching tray. They put the bleaching tray on and leave it in. The bleaching tray keeps the bleach on the tooth from the outside. It stops the other bleach from leaking out. So they get the tray and they get the bleach and they get the micro brushes to be able to clean the food or whatever bleach gets inside. What do they apply? Inside the root. They apply it on the access cavity inside the tooth, and they apply it into the bleaching tray, and then they place it. I'm afraid I don't have pictures, no. Next time I do it, I'll take pictures of, actually I will have somewhere and I'll try and hunt them out and I'll email them to Lou because I'm sure I've got it somewhere. There was one or two more questions, I think. Is composite, no, that's permanent. If you do, question is composite to repair the porcelain a quick fix only? No, that works. If you do it properly, it lasts a long time until they bang it again. In dental school, we're never given a chance to repair porcelain. We were told it's not possible. I can assure you, Sneha, it's possible. I've done it many times. And the guy that taught me, Nasser Baghi, he's done all the research on it and there's papers on it. So it's definitely, yeah, you can only use bite ring on the Fatima, sorry, yes, on the RAP recording, you can only use bite ring material because you have to squirt it in and you have to wait for it to set. You can't use wax, it can't be done with wax. It'll distort, so no. Said that, thank you very much. As I'm not English, what is RAP? I'm so sorry, I thought that everybody knew what it was. RAP is the retruded axis position. It's the position that is the most relaxed, and it's the position that most restorative dentists work with. If you're not, if you don't know what RAP is, then I suggest you that tip you ignore because it's not something that you would use. It's only something you're going to use when you've done a little bit more knowledge about occlusion. and it's perhaps not a tip for you. So I'd probably just ignore that one. So yes, that's correct. Yes, so centric occlusion. No, occlusion has two languages, doesn't it? It has the Pankey-Man, Shiloh, and the Nathology. RAP is I'm talking a different language. So yes, it's centric relation is what it's similar to, if you understand that terminology. But yeah, hopefully that's all the questions done. Great webinar. Do you run hands-on courses? Yes, Venetia, I teach on the tips and training. You know, the one that I said in the beginning, the restorative course. I am one of the clinical demonstrators and lecturers on that. So I teach on that and other course, but I don't have my own course. You know, I'm just a follower. I'm not a leader, and so I just teach on the tips and training courses. I do have days where I do the whole lecture myself, the whole day, mainly on veneers. That's my thing, you know. I can talk about veneers because I've learned so much from Paul and from NASA, so I can put those into practice. So hopefully I will see you one day. I think that's everything, Lou. So
yeah, no, a great webinar, Ash. Yeah, it was great. Lots of questions there, didn't you?
Yes, lots of questions, and I enjoyed all your questions. Thank you very much. Thank you very much for staying up so late. 1.5 hours in the end. I never thought I'd get that.
Yeah, no, it was great, Ash. Thanks so much. I'm looking forward to Thursdays.
Yes, that definitely will be shorter than this.
Yeah. Okay. Well, I'll see you on Thursday. Okay.
All right. Thanks, Lou. See you soon.
You're welcome. Night, everyone. Bye.
Bye.